I'm really looking forward to hearing how the c-Met exon 14 skipping mutation drugs are progressing. That is very true that biomarker has taken 20 years to develop, and I actually think that the drugs, now that we have better tests, I think that the drugs probably will be more applicable to the right patient population. So I want to see that, but I also want to see PARP inhibitors across different tumor types.
I'm looking forward to seeing ways that other people are using genetic testing, next-gen sequencing, and ways that people are using that to sort through the morass of all the different options for treating patients and such.
Since we're in the process of validating our tumor mutation burden assay, I'm really looking forward to seeing more data on TMB. I saw a study that recently came out, I think just last month, that really looked at TMB and lung cancer, and the predictiveness of the biomarker was quite striking. So that's positive results, but I think they also showed that that a combination of the PD-L1 result and the TMB score may be even more informative. So I think the story with TMB just keeps getting more and more complex, and so it's always interesting to hear updates on that.
So the study I'm most eager to learn about is the HER2CLIMB study. And this is a study of tucatinib, which is a small molecule inhibitor of HER2, selective to HER2, so you don't see the side effect profile associated with EGFR inhibition. Another unique component to this compound, it is brain permeable. And in the HER2CLIMB study, which is a randomized phase 3 study, patients are randomized to receive capecitabine and trastuzumab with or without tucatinib. And I think the design of this study was very inclusive for patients with brain metastasis, essentially patients with stable brain metastasis, progressive brain metastasis, and even small untreated lesions that were asymptomatic were able to be enrolled into this study. So we're very hopeful that the addition of tucatinib to our standard backbone of capecitabine trastuzumab will prove effective for this patient population.
So the one study that I'm really looking forward to hearing more about is the Keynote 522 study. And I am looking forward to finding out again what the pathologic complete response rates really is above that of chemotherapy. We know that it met its primary endpoint, but had two primary endpoints of path-CR and event-free survival. So I anticipate that path-CR will be the one that's reported out here in the near term. But it will be very important to understand exactly how much path-CR was achieved with the use of pembrolizumab above that of chemotherapy. And then two, what biomarkers or analyses did they run to identify the population that might benefit the most or least from that drug? So those are really some key things that I'm looking forward to in the near term. Also, I'm looking forward to seeing how the PARP inhibitors in combination with checkpoint blockade work out, especially in patients who have either homologous recombination deficiency high or germline BRCA mutated samples really pan out, because that again is biologically rational and it makes a lot of sense. And I hope for all our patients that we see improvements in their overall outcomes.
The extension of the overall survival data in the CDK inhibitors, I think, is still going to be important. So that would, and I think, immunotherapy data that's going to be coming out at ESMO also in the breast space for early stage treatment and factoring in immune checkpoint agents and triple negative disease for early stage disease. Those are going to be the results that I think are going to be most headline grabbing.
I think we're all really excited to hear the overall survival from Monarch 2, because everyone that treats breast cancer just wants to know the impact of these therapies is improving the survival of the patients that we're giving them to. I also think as we tease out the populations specifically within each trial, who's receiving the CDK4/6 inhibitor is very different. The inclusion criteria within each trial was different. So as we tease out the overall survival benefits and the patient populations of each trial, figuring out if all women will truly benefit from receiving a CDK4/6 inhibitor in the first line is going to be really important.